The second chairperson, Dr. Hussein Halabi. As you all know him, he is a senior consultant rheumatologist at King Faisal Specialist Hospital and Research Center in Jeddah, and the former president-elect of the Society and Arlar. So the stage are yours, Dr. Halabi.
Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Wassalatu wassalamu ala Sayyidina Muhammad. Thank you very much for the kind introduction and invitation to this beautiful conference. It's my pleasure actually to co-share this first session today about connective tissue disease with my colleague, Dr. Hiba Al-Hajri from Kuwait. So without any further ado, I'd like to present the first speaker for the session, Dr. Aus Abu Abad. Dr. Abu Abad, he's an assistant professor and consultant rheumatologist at King Saud University in Riyadh. He will speak to us about the cancer screening in idiopathic inflammatory myopathies. Dr. Abu Abad.
Is there a slide clicker or? And then I use this one. Okay. All right. Good morning, everyone. I think nobody wants to start their morning on a Friday to talk about cancer and malignancy screening, but hopefully we'll make this work. Today I've been given the task to present to you the most recent guidelines in cancer screening in idiopathic inflammatory myopathies. So idiopathic inflammatory myopathies poses a challenge to us as a rheumatologist, especially when it comes to cancer screening. There are many questions that are unanswered. First, do we have to screen every patient with myositis for cancer? The second question, how invasive should we screen patients for cancer when they present with myositis? And the third question is, how frequent should we screen them if the initial screening tests have been negative at presentation? So this guideline was published last year in 2024 by the International Myositis Clinical Assessment and Outcome Groups, led by Rohit Agrawal. And they was published in Nature Reviews, and their goal was to hopefully standardize the cancer screening process among inflammatory myositis patients. So there's an increased risk of cancer in inflammatory myopathies, particularly in the first 3 years of diagnosis. And up to 25% of patients who are diagnosed with cancer are diagnosed within the first 3 years. The common malignancies in inflammatory myopathies include lung cancer, ovarian cancer, colorectal, lymphomas, breast and nasopharyngeal carcinomas. And it is the leading cause of death in myositis patients, inflammatory myopathy patients. The unfortunate truth is that the majority of patients, 83% of patients, when they are diagnosed with cancer, are diagnosed at stage 3 or stage 4 cancers, which is quite unfortunate. So hence, early screening and early detection of malignancies associated with this condition is paramount. So I'm going to talk about, so I already talked about the initiative. So we're going to talk about their methodology. So the methodology of developing these guidelines, they did a meta-analysis and literature review of all the evidence up until April 2022. And then they had an expert group of myositis experts among neuromuscular neurologists, rheumatologists, pulmonologists, and they also had cancer screening specialists or experts from oncology as well. And they had a diverse group of 75 members across 22 countries and across all the continents, essentially. And they had a modified Delphi method approach where they had series of questions and recommendations that were voted on by the panel. And they drafted the recommendations based on their survey responses, and they graded the quality of the evidence using the GRADE methodology. Was it strong, moderate, or low evidence? And they had recommendations classified as strong or conditional recommendations. So we're going to talk about the recommendations right now. So they had a total of 18 recommendations. The first 4 were strong recommendations, and the rest were conditional recommendations. So we're just going to talk about them one by one. And you will notice that probably the majority of these recommendations are common sense, except when it comes to the conditional recommendations where they try to tailor the screening recommendations to patient's phenotype, and that is essentially was based on an expert opinion. So the first 2 recommendations is that they identified, and I think we already know this as rheumatologists, identified low-risk clinical phenotypes of myopathies that usually do not require cancer screening. Those are the juvenile onset dermatomyositis subtype and the inclusion body myositis subtype. So we already know that these clinical phenotypes or subtype of myositis do not carry a malignancy risk. The third recommendation is that all patients with inflammatory myositis need to go for their age-appropriate cancer screening within the country of origin recommendation guidelines, which is essentially a common sense recommendation. The fourth recommendation, which is quite interesting, is that they recommend that any patient with new onset inflammatory myopathy should go for myositis-specific antibodies and myositis-associated antibody testing. This is quite important because new knowledge over the last decade indicated there is a clinical phenotype of myositis patients and a specific antibody profile that increases the risk of cancer. And I think this is, has been probably celebrated knowledge over the last 2 decades of TIF1 gamma and XB2 antibodies carrying the highest risk. The fifth recommendation is that patients with adult onset inflammatory myopathy should be stratified according to their myositis phenotype, the autoantibody profile, and their clinical features. And I'm going to just dissect this over the next recommendations in a second using a nice diagram that they developed. So that is the diagram, and I hope this is projecting well. So if you see on the extreme left and right that you do not really need to screen patients for cancer if they have juvenile dermatomyositis or if they have inclusion body myositis. If they have an adult onset inflammatory myopathy, then you need to categorize them based on their myositis phenotype, their myositis antibody profile, and their clinical features. So if you look at the extreme left on the slide with the high-risk factors of malignancy, you will see that the dermatomyositis subtype, this is already known knowledge, carries the highest risk. The myositis-specific antibodies that carries the highest risk of cancer are the TIF1 gamma and NXP2 antibodies, and there are a collection of clinical features that are they essentially were associated with increased cancer risk. Later age of onset, above the age of 40, if they have persistent recalcitrant disease activity despite initial therapy, if they have severe, moderate to severe dysphagia, and if they have cutaneous necrosis. So these are the highest risk factors for malignancy. And typically, if you score 2 or more points on this left side of the table, then you are considered a high-risk patient for cancer. The intermediate risk factors include the three subtype of myositis of clinically amyopathic dermatomyositis, polymyositis, and necrotizing autoimmune myopathy. And their associated antibodies as well. SAE1, which is a common antibody that we see in the pure dermatomyositis subtype, HMG-CoA reductase, which is associated with the necrotizing autoimmune myopathy, Me2, which is also associated with dermatomyositis, and MDA5, which is associated with a distinct phenotype of dermatomyositis that increases the risk of severe progressive interstitial lung disease. The MAL6 is also considered as an intermediate risk factor. And then the protective, kind of quote-unquote protective low-risk factors are the antisynthetase syndrome and a myositis that is overlapping with another systemic autoimmune rheumatic disease, and these collections of autoantibodies that are on the right side of the table, the SRP antibodies, which is associated with necrotizing myopathy, all of the antibodies that are associated with the antisynthetase syndrome, the Jo1 and the non-Jo antibodies. And if you see the clinical features on the right side of the table, you see that these clinical features like Raynaud's phenomena, inflammatory arthritis, and interstitial lung disease, these are the same clinical features that we expect in the antisynthetase syndrome. So we now know that the antisynthetase syndrome per se, as a phenotype, carries a low risk of cancer. So once you stratify your patient based on this table, you determine their risk. So if your patients score 2 or more high-risk features, this is considered high risk. If they score 1 high risk and 1 intermediate risk, they're considered intermediate risk patients. And if they score, essentially have low risk or protective factors, they're considered low risk. So what do you do with them? And that's, I think, the second most important questions that we're faced with. So if your patient is screening at the time of the diagnosis with basic screening panel, basic screening panel means essentially the same investigations that we do when the patients essentially present with myositis. So these are the common investigations that we do. We do a comprehensive history, a physical exam, a CBC, a liver function test, inflammatory markers, serum protein electrophoresis, urinalysis, and plain chest X-ray. I think most of us as rheumatologists do this test when the patients present. So that is the recommendation, is you do this once at diagnosis, and if they don't have cancer or malignancy or abnormalities, essentially, that warrants further investigations, that you stop. And they recommend that you do not do further testing after that. So you do it only at the onset of diagnosis if they have low-risk factors. What if they have moderate risk factor in the middle table? Then you essentially do a basic screening panel, similar to what I just showed you, in addition to an enhanced screening panel. Enhanced screening panels include CT scan of the neck, chest, abdomen, and pelvis, cervical cancer screening for women, along with mammogram, prostate-specific antigen for men, and CA125 for women to screen for ovarian cancer, as well as transvaginal ultrasound. They also mentioned fecal occult blood, but when you look at the recommendations, can be substituted with colonoscopy if your country-specific cancer screening guidelines recommend colonoscopy for colon cancer. So they recommend for intermediate risk patients to do the basic and enhanced screening at diagnosis, and then you stop. You do not need to repeat the testing in the first or second or third year after diagnosis. How about if you have high-risk features, 2 or more high-risk features on the table that I showed you, then essentially you do the basic along with the enhanced, but you keep repeating the basic at 1, 2, and 3 years after diagnosis, because these patients carry a high risk. And there they have some recommendations around PET scans and endoscopy and nasoendoscopy, which I'll talk about in a second. So the recommendations about PET scan, this is all conditional recommendation based on expert opinion. So it doesn't stem from high or strong evidence, so mostly observational, low quality data, is that you can consider a PET scan in patients with high risk where the investigations did not yield a diagnosis. So you can add it after you do your basic and enhanced testing. And you can consider PET scanning as the single screening modality for cancer in those patients as well, especially if they have dermatomyositis as a phenotype with their age of onset above 40, along with TIF1 gamma antibodies. So if you have essentially triple risk factors for malignancy. So you can consider a PET scan as your essentially first line. And there's conditional recommendations about doing an upper and lower GI endoscopy for high-risk patients if your initial basic and enhanced screening is negative. And they recommend considering nasoendoscopy to screen for nasopharyngeal carcinoma in countries where nasopharyngeal cancer is common. And speaking to my head and neck cancer colleagues and radiation oncologists, they actually would recommend it within our population as well, because they are facing or seeing a significant number of nasopharyngeal carcinomas in their practice. And the last recommendation is essentially a common sense, is you essentially have to do the testing if your patients present with constitutional symptoms or red flag symptoms. That is fever, weight loss, appetite loss, or family history, as well if they have a smoking history or night sweats. And that essentially concludes the recommendations. I think this recommendation is quite helpful because there is a wide variability and in practices among us in screening for cancer in such patients. So I think that although these recommendations did not really stem from prospective or good quality data, it essentially stems from retrospective and observational data, but I think it's a good start to standardize screening among rheumatologists in this myositis sphere, and hopefully improving patient outcomes and detecting cancers early. The limitation of the recommendations, that's limited evidence-based, and there is a need for high-quality studies. And although there was a geographic diversity in the expert group representation, but it did not include multiple regions in the world, including our region as well. So I think this is a good start in terms of the recommendations, and hopefully that we can build on future research and apply it to our patients, see if this is cost-effective and it's applicable in our population, and a positive step in the myositis research. And with that, I conclude. Happy to take any questions.
Thank you very much, Dr. Abu Abad, for this beautiful presentation and for being on time. So it's my pleasure to present the next speaker. He's well known to all of us, Professor Mohammed Amer. He's a consultant rheumatologist at King Saud University in Riyadh, and he will entertain us in the coming 20 minutes about updates on Sjogren disease diagnosis and management.
بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد صاحب أجمعين. I would like to thank Mr. Chairman for the kind introduction and the scientific committee for inviting me to give a talk about primary Sjogren syndrome and the most recent updates. So just to announce that we have the fifth and probably the last rheumatology crash course. This course is retiring this year. And we thought to memorize Professor Ayman Ballah, who is the first rheumatologist in the history of Saudi Arabia. And actually, he's the first one who published a paper on cancer and dermatomyositis in the 1990s. So this course is for fellows. It's going to happen in the next 3 weeks, and we welcome all fellows to attend this final course. These are my disclosures. This is the objective. So basically, we're going to talk just about primary Sjogren syndrome, because secondary Sjogren syndrome has different aspects that might not be similar to the primary subtype. So basically, primary Sjogren syndrome is a disease that mainly affects extraglandular glands, exocrine glands, and cause Zika symptoms: dry eye, dry mouth, dry skin, vaginal dryness, GI and respiratory dryness, all causing chronic symptoms and reduced quality of life. They will have extraglandular activities and manifestations related to B-cell hyperactivation, such as arthritis, rash, cytopenias, ILD, demyelinating disease, scleritis, and others. And it is the most common rheumatic disease associated with fatigue, which has most probably a negative cytokine profile that do not respond to immune modulators, and finally, the increased risk of lymphoma, where these patients have a significant increase in non-Hodgkin lymphoma. Now, if you go to the pathogenesis, about 20 years ago, salivary gland epithelial cells have been described as important pathogenic cells that play a central role in the development and maintenance of inflammation and autoimmunity in patients with Sjogren's syndrome. So basically, they express HLA, DR phenotyping, which transform them to antigen-presenting cells, leading to B-cell activation and T-cell co-stimulation, secretion of different cytokines. When they go into apoptosis, they release SSA and SSB antigens that are the targets for the autoantibodies, and they lead, of course, to activation of many adaptive and innate immune pathways, including Th1 and Th17. Now, if you could see in your upper left slide, these cells, which are triggered by an environmental factor like a virus, which cause release of different cytokines and the activation of the adaptive immunity. And there is a lot of role on the co-stimulation between B cells and T cells, or antigen-presenting cells and T cells. This was also lead to a minor activation of the Th17. And because of this recognized pathogenic roles of many different pathways, many drugs have been implicated. So I'm going to show you in these two slides what are the targets that had any positive results, either immunological results, subgroup analysis results, or a primary outcome related to outflow stimulation, patient-reported outcome, or an extraglandular manifestation. So you could see tocilizumab trial was negative. You could see here nipocalimab and efgartigimod, which are neonatal FC receptor blockers that reduces the trafficking of IgG antibodies. And you have tibulizumab that has mainly affect the Th17 cells, have some positive results. The main studies that shown negative results also, the hydroxychloroquine study, the Joker, the famous French studies. The two rituximab clinical trials were negative, especially for the patient-reported outcomes. And there are some conflicting data on the co-stimulation. So you have some co-stimulation molecules that have preliminary phase 2 studies that have positive effects or met their primary outcomes, and you have some studies that in the phase 2 clinical trial with small sample size have not met the clinical outcome. It's really related to what the company would decide to go for phase 3 trials or not. So there are many other co-stimulatory targets that we are borrowing from the oncology literature, apart from abatacept, including the iscalimab, also the frixalimab, which work mainly on either the CD40 and CD40 ligand or the induced co-stimulation. Now, like lupus and systemic sclerosis, Sjogren's syndrome clinical trials have failed partially due to the outcome measures that have been developed because they might not catch a subgroup of patients or might not cover the efficacy of the agent on a specific domain. So basically, we have the EASDI, which is the Euler Sjogren's syndrome disease activity index, which mainly looks at inflammation extraglandular activities. And if you could see, it's either 0 or it's a big number, 3, 4, 5, or even 10. Now, the only ones that have small numbers are the biological and the hematological. And I want you to remember this point when we're going to look at the new outcome measure. Then you have some corneal staining